In 1948, the World Health Organization defined the definition of health to be a complete state of physical, mental, and social well-being, and not just the absence of physical illness, but to also include oral health in a person's state of well-being. The prevalence and need for preventative services increased as investigators and practitioners in the 1950s and 1960s discovered that dental caries and also periodontal diseases were in fact bacterial infections. Researchers were also able to identify and demonstrate that these infections can be prevented by increasing host resistance to disease and reducing or eliminating suspected microbial pathogens in the oral cavity. Oral health affects our ability to eat, speak, smile, show emotions, and also affect a person's self-esteem, school performance, and attendance at work or school. Approximately 23% of children aged 2 to 11 years old have had at least one primary tooth with untreated decay, and 20% of adolescents aged 12 through 19 have had at least one permanent tooth with untreated decay. Factors that contribute to poor oral health include social determinants of oral health and the limited oral health literacy of the target population. Studies show approximately 30.2% of children and adolescents aged 2 to 18 are at below 200% of the federal poverty level received a preventative dental service during the past year in 2007, and more than half of low-income children without health insurance have had no preventative dental care visits. Dental caries are bacterial infected tooth surfaces which destroy the tooth enamel, resulting in tooth decay, and are among the most prevalent and largely preventable chronic conditions that affect African American and Hispanic children in disadvantaged populations and underserved communities. The low use of dental care and preventative dental services among low-income children that are at high risk for dental problems is likely associated with financial barriers and low oral health literacy. In disadvantaged populations and underserved communities, oral health risk is elevated throughout the life course due to socioeconomic status, discrimination, and lack of eligibility or high out-of-pocket costs for public and private insurance coverage. Socioeconomic groups with low levels of dental use, such as African Americans, Hispanics, households with low family income and low educational attainment by the head of household, have been documented to have higher prevalence of untreated decay than the general population. The Patent Protection and Affordable Care Act, signed into law on March 23, 2010 under the Obama administration and largely upheld by the U.S. Supreme Court in June of 2012, authorized several major changes in policy and funding related to oral health. One benefit of the Patent Protection and Affordable Care Act is that it allocates funding to increase water fluoridation in communities to prevent tooth decay among people from different socioeconomical, racial, and ethnic groups. It also created school ceiling programs for children who may not receive regular preventative dental care. The PPACA policy created a greater awareness to the idea that a personal oral health has effect on your physical health. Evidence has shown that oral infections are at risk for a wide array of physical illnesses, including diabetes, respiratory disease, and cardiovascular conditions.